So I'd like to take this up just quickly as we get started here and tee it up again. We're back in this how part of this, and so now you're going to start to see the guts of this process. I'd like to take just a quick minute as we're getting set up. Everybody who's a care provider, you guys stand up for a minute. Who has some kind of patient care responsibility. How many of you wake up in the morning, remain standing, if you wake up in the morning and you come to work and you want to do a great job? Obviously nobody sits down, right? Now, sit down if you think you need better tools with which to do your job. It's not like there's no last man standing. So that's really the guts of what we're going to talk about here, is this idea of how do you build these tools to execute on the stuff that Bob just talked about. So as you think about this idea, put this up as this graphic, this idea of the three-legged stool of population health. The idea of saying that you need some oversight tools, and you're going to see our population health tool. You need some provider tools, because a lot of what we do still is health care, right? It's one-on-one sort of interactions with patients. So you need some good tools from a provider to patient kind of process. We've got our acute foundations tool and our CI scorecard. Then you're going to see some really cool stuff a little bit later that Beth, Gray, and Allison are going to talk about. This idea of how do you get to consumer engagement. I want to talk just briefly about this idea of the power of pull. Because this idea of scorecards, the idea of behavior modification, of collecting data, is threatening to a lot of us. I think Werner said the other day, that we should be scared. Well, I think it is a little threatening to providers to do that, and I've earned myself some antipathy from a lot of you guys out in the community as we've tried to get this stuff rolling. But this is important, because the power of pull, and what Bob said about the way things used to work is that you'd get an analyst, you'd generate a report, you'd send a report to somebody. And as a doc, I used to get those things all the time. And any docs really pay attention to that stuff that comes in paper from the payers, et cetera. Most of the time, it's out of date. It sort of ends up in the circular file or in the shredder. That push idea isn't very effective. This pull is absolutely staggering. And we have, this trend line keeps going up. There's like 14,000 hits on these things where providers like you guys who stood up go out and actively log into the tool to look. Some of that is because you're irritated at me for putting stuff on there, but some of it is because you're actually looking at the information to do something different. And the ability and this engagement of our providers to be willing to look at that information, this power pull is staggering. Anybody ever seen anything like that where you got 500 docs who actually go out and actively look at a tool to help them do performance improvement? That's pretty huge. And the final thing, and I stole this slide from my friend Kurt Seppi, in God we trust, everybody else better bring data. So that's what you're going to see now is data. And so I'd like to introduce Dr. Brian Fortune, who's the chair of the Magic Valley PLC, and Allison Irwin, who maybe is smarter than Bob, and she's way better looking. So. All right, so as we get this process going, and Brian, I've probably alienated so many docs here, I'm looking for a decent doc somewhere else. Are you any good?
Yeah, I'm fine. I'm a good doctor.
Yeah, well, how do you know that, Brian?
Well, I've got diplomas on my wall, so I went to med school.
Yeah, and you probably get paid too, right?
Yeah, I get patients come back.
Yeah.
And they don't all die.
That's largely for the Vicodin prescriptions?
Yeah, well, I'm a good doctor. And actually, my daughter's playing basketball, and my mom and dad are here. And Mom, you think I'm a good doctor? My mom's back there. So my mom says I'm a good doctor, Jeff. How about that?
Yeah, I don't think that cuts it, Brian. So as you think about that, how would you know if you're a good doctor?
Well, I think that's part of what the transition that we're looking at, and we're kind of making a joke about it. But in actual fact, a year ago or more, maybe 18 months ago, how would I tell if I was a good doctor? I'd feel good about it. Maybe somebody paid me a compliment. I get honorable mention in obituaries from time to time about doing good care.
Yeah.
I'm an internist.
I'm not sure that's actually a productive thing there for
I'm an internist.
Maybe in magic it is, I don't know.
But the point is, I had no real tangible way of saying, where am I doing well and where am I doing poorly? And what we have in front of us here is just what Bob was talking about, this is the feet on the ground, or the nuts and bolts of how can I find out where I'm doing well and where I'm doing poorly. And I'll tell you something about this. First of all, I don't have any PowerPoint slides. So hopefully, nothing against people with PowerPoint slides. I'm just saying, ouch. I don't want anyone to fall asleep. But anyway, so this is actually what we can look at as physicians, and the docs will recognize this. on our screens, and once a month the data gets refreshed and we get emails, and we can go and open up this scorecard and we can look at the data to our practice. And if we walk through it, I think you'll see how this helps. This is one of those tools that we all sat down about in a minute ago, the tools that I can use to find out where am I getting it right and where am I doing wrong. And a large percent of the time I'm doing it right, but there's a bunch of patients that are falling through the cracks, if you will. So I'll walk through how this tool looks. So you see this trend line, the blue line, and those are my actual points. And the points are broken down into metrics that are in 4 large categories: better care, lower cost, patient-centered, and better health. And those are all specific clinical metrics that we'll get into in a minute for people who haven't seen this. And they all are given a point score, and my performance on each metric provides a point to me. And if I go back to the top, I get 460 out of 502 total points for the care that I deliver. And this has been designed over the past couple years.
I want to stop just quickly, Brian, because we get some heat from providers who say that some of these metrics aren't impactful for what they do. We should clarify that, because this thing is built around external measures that we're being measured to right now. So this is things like the Medicare Shared Savings Program, meaningful use, PQRS. So I agree. So you guys who maybe are in the surgical subspecialties, et cetera, this is really largely built as a proof in concept for you guys. What we're going to do over the next period of time is come back and ask you guys for impactful metrics for what you do. This is really built around primarily primary care kind of stuff. I want to make sure we level set with everybody.
So these are my actual data. So this is my performance, and I don't know, I think I have probably a couple patients maybe in the audience, and hope you guys stay with me on this. But it's a little bit of a gut shot, and we heard yesterday talking about transparency and accountability. And for about the past year, people have been showing my numbers around the system, and I started doing it, about a year and a half ago maybe. And I'll tell you something, it takes a lot to do it, because a lot of times you feel kind of like, oh my gosh, what's it going to show? What are people going to think about me? So if I'm willing to actually look down at the nuts and bolts of my practice, there's going to be things that turn out that I'm not doing very, very well at, right? So it's a little bit embarrassing, and it's a little bit tough to do. And I think the rest of the physicians in the audience may understand how that feels when you see your data up there, and there's something you don't do well at. Physicians are used to getting A's, right? Ever since kindergarten, we all get A's, and that's how we get to med school and all that. So when we get a B on something, it's really rough. And I think that's an important thing to talk about. That culture of transparency is very difficult to get to, and I find myself struggling with it. So anyway, back to what we have here. The blue line is my performance, which thankfully right now is above the triangles. The triangles represent the other internists in the St. Luke's Health System and where they're performing in this. And you can see the trend moving around. We do have a capacity to go to the leaderboard, and you can see who's doing well and who's doing poorly. And part of the reason that's important is because, and we'll get to this in some of the other data metrics, is those silos that Bob talked about, or those islands. If you think about the practice of medicine, a lot of us practice our medicine in our office with our patients, and we have very little interaction with our colleagues until somebody gets sick enough to need a consultant or to need help. But this allows me to say, gosh, I'm not doing too well here or there. I can find out who is doing well, and I can go talk to them and say, what are you doing different? How are you doing it? And it starts that intercollegial conversation in a different way than we're used to having.
So let's see the guts of this thing, Brian.
So let's go to it. So if you go to better care, Allison will scroll down, and you'll see that we'll talk about diabetes. So diabetes is a big ticket item in healthcare, and that's a very difficult condition to treat. And if you look, 36% of the time I'm getting it right. So in terms of the metrics of cholesterol, the hemoglobin A1C, which is a measure of average blood sugar control over the preceding 3 months, the blood pressure, I said cholesterol, not smoking, and taking an aspirin for high-risk patients. So those are sort of the big things that we're trying to do. And you can see I'm in the green. I'm getting 20 points. I feel really good. That's super good. But if you look down here at, say, the 12% down here, did you want to go that one? If you go to diabetes A1C greater than 9, so those are the patients where I'm doing poorly. So I want to talk a little bit about my philosophy in healthcare. So I used to be your body, your choice. Come see me, give you advice. Here's how you do it. I'll prescribe the meds. See you next visit. They come in next visit, you're still doing poorly. Here's my advice. Here's the meds. See you next visit. And I'm not proud of that, but that's what I was. And I feel like I should have I'm Brian, and I was a reactive doctor. My life is unmanageable. But anyway,
I'm sorry, Mrs. Fortune, you had to see that.
We'll have a prayer later. But anyway, so when I look at this, it starts to, I'm on the hook here. It's no patient left behind for the educators, right? I mean, I don't really like that, but think of that in a positive light. And I can say, well, I can see up here, I've got 23 patients whose A1C is greater than 9. I'm getting an F on 23 of my patients out of 194. So who are those patients? So I can, the way this tool is so powerful is I can click on that and I can hit that, see that show PHI? Christy, where's Christy Newhoff? We won't hit that button, but that shows the patient name so that I can find the 23 patients, their name and date of birth, who they are, whose A1C is greater than 9 in my practice. Why do I care about that? Because then I can call those patients on the phone or I can do something different than I'm doing today. So I'll give you an example. A patient by the name of Bill, I've been working on him to get his A1C down. It's higher. He's actually a teacher and a pretty sophisticated guy, but he's just not doing, you know those 3% of people that don't smoke, wear their seatbelt, exercise? Well, he's not one of them. He's a 97%. But so I got the data and I called him and said, Bill, what are you doing? I know you saw the diabetic educator. He says, well, they gave me this thing for my phone to count my calories. You using it? No. Well, why not? Well, I have my phone with me. Who doesn't have their phone with them? I mean, when do you ever not, aside from when you're up here presenting? But besides that, everybody has their phone. Why aren't you using it? So I called him on the phone, talked to him about it. He started using the app. And I swear to you, God is my witness, his A1C came down below 9. So he's no longer one of the 23. He's in the 8 to 9 range. He's not below 8 yet, but he's getting there. And he said to me at the next visit, he says, I've never had a doctor, 15 years diabetic, never had a doctor call me at home, ever. So I look like a rock star, right? Because I called him at home. And my numbers start looking better. And we're starting to get at, how do we do something different? I don't know I need to do something different until I have the data in front of me that says what I'm doing just isn't working 12% of the time, or whatever percent.
So do you have to go that alone, Brian, or can you get some help from your compatriots in your peer group? Can you like click on that sidebar and find out who's a good performer?
So that's a great example. If I hit this here, I can say to myself, what is it I need to do differently, and how do I need to do it differently? And obviously, I'm doing the best I can, right? I'm trying really hard, and I went to a good school. My mom likes me. But I'm still not getting it right 12% of the time. So I can go here, and I can go to Marsha Whitty, who's doing great. I can go to, and she's in McCall, and she's a great person, but it's far away. But if I scroll down a little bit, I can get to my partner. He's at 6%. He's in the office next door to me. Never asked him about how he treated a diabetic before. Go to Daryl Philp and say, hey, Daryl, you're at 6%. How do you do it? His first response, don't listen. Well, I use the expensive meds, that's why. But we got through that. Sorry for whoever's on the pharmacy benefit plans over there. But we got through that, and the truth of the matter is he sees his patients a little more often. He uses the diabetic educators more than I do. And so starting to look at how he does things differently helps me to be a better doctor by finding out what's the different way to do it.
Well, maybe your patients are just sicker.
Well, that's a possible answer, but we'll get to that in just a minute if it's all right. That's a good segue. You must know the presentation. But now you've screwed up my train of thought, so now I'm done. The one other point I want to say is that the way we're practicing medicine, the system in which I practice has to change. So instead of me calling those patients, my nurse is calling those patients. Instead of me being remember Marshall Preach sat up here and talked about in med school, the doctor was the captain of the ship, everybody else took orders. I have to change my culture to be on the team so that my nurse, my diabetic educator, my nutritionist, everybody is reaching out to the patient. And that patient I told you about I called, he had just gotten back from his diabetic education meeting, and by calling him, that got him activated in doing that. So this patient activation frustration that, I forget who asked the question yesterday to Nash, this starts to help us find ways to get at that, because I'm not on the hook per se, but people are seeing that yellow bar, and that's a little frustrating for me. I want that to be green like Ficklins. All right, so what's our next?
HCCs, let's talk about
So
those.
Geoff talked about my patients are sicker. So there are a list of 12 things or 15 that physicians say always when you bring them their data. The data aren't accurate, first of all. My patients are sicker is the favorite one. I'm such a good doctor. I have all the sickest patients. I guess you could argue I'm the bad doctor because they all got sick, but that's another story. If we go to what's called HCC risk score, so that's a risk score calculated through the payments based on the acuity of the illnesses that the patient has. And actually, we have a better way to explain it, I think. And maybe we'll talk about this for a minute, how this tool helps us. Because if you notice this screen on the right, you're right, yeah. So that has sort of my data over time. It has where I fit in the scatter plot compared to the peers. My peers are all the other triangles. I can get to my peers. You saw me do that earlier. And then I can hit this info button. And when I hit the info button, it tells me how are those data collected. Is this from the electronic medical record? Is this from an insurance claim that's been dropped? What's the source of that? And what's the numerator, denominator? How many points are with each one? HCC doesn't have points with it, but the other ones do that. So it's a powerful tool in that it shows me how I'm performing. It shows me how I'm measured, what the measurement process is. And then it also gives me information about that.
We've built a bunch of things in here. If you scroll back up, Allison, quickly around the triple aim, this idea of being able to collect metrics in better care, better health, lower cost. I also want to call out just quickly the idea of patient-centeredness, because we've talked a lot about that. And there's a survey process that CMS will do called the CG CAPS. And this survey is administered to people on an either annual or a biannual basis, depending on what kind of program you're in. The challenge with that is it's just like those STAR reports that I alluded to earlier, that you get this big chunk of abstracted data on a population or a system level that tells you what your performance is in the rearview mirror. It's not a proactive tool that allows you to actively manage the process and to improve your processes. Because frequently, and we've talked about this before, it's not bad people, it's bad process. We've never had the discussion, we've never seen the data. So we pulled together this patient-centeredness survey that a lot of you as office managers or providers have seen, and it's very simple. It's an optical scanner form, but what it does is allows at each individual patient level to ask a couple of these core questions. Do you as a provider, are you effective in engaging your patients in shared decision making? Being able to measure that and being able to improve that process is huge, because what do people want from us? They want somebody to listen to them, to help them make a decision, to not autocratically tell them that, to include them in the process. We now have the ability to take a look at those kinds and pieces of information as we go through this. Are you using it, Brian?
Yeah, I use it a lot. I think one of the challenges here, so picture this, you got a physician, autonomous physician, highly trained professional, smart person, and you're going to tell them that you're going to do these surveys and give them the information. I think of all the pushback we've gotten, the surveys is one of the big items where we get pushback. And I believe it's a philosophical problem. So my problem is if I look at the surveys as a punitive measure, so picture the mechanical system Bob drew, if there's a top-down person that's pushing down on me, using my survey to scrutinize me, to pay me more or less, or employ me or not, then that becomes a very frustrating thing, because now this is a punitive measure. It's a big stick behind me. But if I look at it as a window into my practice, and also if you go to time spent with, do timely care or time spent with patient, either one. So if you look at that one, you'll see that, I logged out. You'll see that my performance was pretty poor before. I mean, the time spent with patient wasn't very good. And it occurred to me, why is that? I never really thought that that would be something that patients would care. I thought they'd want to spend less time with me and get out of there as quick as they could. But in actual fact, when I saw that, I pulled some articles on, how do you engage with patients and make them really feel that you genuinely, are spending the amount of time that they want you to spend. And there were some little pretty simple things like walking to the front desk and spending a little more time with them after the visit and those sorts of things. So for me, it was an opportunity to have insight into my own practice in a way that I couldn't have before, because patients don't really say that, or wait time for appointments. My nurse will tell you that I'm much more on time today than I used to be. I mean, I'll be late to my own funeral probably. But the point is that this is giving me incentive to try to be more on time with the patients. Of course, I had one patient say, you're on time. Is that because you're not a very good doctor? Are you not busy enough? Is that what that is? So, and then interestingly, if you look at, I think it's interesting, provider rating, I'm 83%. So I need to have my mom fill out a survey, I guess, or something to try to get a few more in there. But I think the point I'm trying to make is if I can embrace this as an opportunity to get insight into how I'm interacting with my patients and how I can do a better job of that, then it's a very useful tool. If, on the other hand, it's just seen as a punitive measure that they're going to use, Big Brother is looking over my shoulder, I think it loses all of its power and all of its ability. The other thing about it is that CG CAPS is Big Brother looking over our shoulder, and it is the payers looking that are going to put or implement that and pay us based on HCAPS does that and CGCAPS in the clinic. And so this gives us a proving ground to find out how we can do a better job of more patient-centered care in the individual practices.
So this is a very powerful performance improvement tool. And if you look at, and the screen that you're looking at right now really looks at the entire Magic Valley cohort. And you look at the performance back from February till December of this year. I think that's very powerful. You know, we ought to give our peers in Magic Hand and applause. That's really powerful information that they've actually executed on this process. And this is a good segue, I think, to take a look at our other process, our other tool, because this starts to look more at what would a population manager look like. So we've looked at the sexy part of this in the ability of providers to have more and better information about how they do their care, the insight into registries that patients that may or may not meet a particular metric. What you're going to see now is what we call the population health tool. Because as we move into this idea of managing populations, the first part of that is to get appropriate information so that we have the ability to understand where care occurs. We start to look at this more from the population manager perspective. And so this tool is very powerful. It is not designed to be used at the bedside. This is designed for guys like Fortune and I, Kurt Seppi, Steve Coates, other people to look at where the process of care falls down, where we have opportunities for improvement as we think about getting at this 30% opportunity that Geoff Taylor brought up. So as we move through this process, what you're seeing here is a high-level overview of a sample population. And this looks at a couple of things. This looks at the true finance associated with claims rendered for a population. And this starts to put us in this idea of looking more like we're the custodian of a finite resource rather than a group of providers who's after the resource. And that's a very different paradigm shift than we've ever had, and this tool allows us to take a look at that. So this is a very high-level view of the premium associated. The IBNR is something called incurred but not reported. It's an estimate of claims that are rendered in a particular month that just haven't made it through the system. And this tells you whether you're upside down or right side up as you start to look at this idea of managing a population for an acuity-adjusted budget, being the custodian of that resource and managing the process very well. Allison, we take a quick look then at some of the broad utilization metrics. This allows us to take a look at where are we in our ability to look at benchmarks. So when we're managing a particular population, are we performing more or less services than various benchmarks? We should scroll up quickly, look at the financial page. This resonates with people like Geoff Taylor, should resonate with a number of you business guys in the audience. This tells you essentially what your balance sheet looks like for managing the population. Scroll down just a little bit, Allison. And this also becomes very powerful for providers because what this essentially looks at is for this particular population, for the cohort of docs that you now practice with, it essentially gives you a profit and loss statement for each individual practice for how you're managing patients. And once again, this isn't a judgment call, but it says, well, where do you, perhaps as a clinic or a particular provider, need some help? And that's very powerful. We've never had the ability to look at this. And this is a little bit upside down because my practice is St. Luke's Ada Medical Associates, and this particular population, we're upside down $500,000. And there's reasons for that, and I don't think, Allison, we can scroll into that at this particular time because this starts to get into more PHI information. But this is an insight, it's a window into the ability to start to manage populations, not only as a system, but as a group of docs, and to Bob Locken's point, that is interconnected in ways that we've never been interconnected before, and they're absolutely necessary for us to do that. Allison, Brian, you guys want to take a stab here at some of the utilization?
So I think where the CI scorecard that I was showing is something that I can use at the bedside or in my office for my individual patients. This helps us look at as a population of patients, and we can choose which population we look at based on their insurer, their geographic location, and these sorts of filters. And it allows us to really get that idea that you've seen on many slides yesterday, that a small percentage of the people are consuming a huge amount of this health resource, and helping manage those people optimally is going to be critical to our success if we're really going to try to bend that cost curve or that Jeff Taylor's graph about opportunity. That opportunity is going to be in those people that are maybe not as well managed and not as not plugged in and as engaged. I mean, there's plenty of people that have diagnoses that are expensive, and we need to spend money on them, but we need to be sure that we're doing it the most effectively and the most efficiently.
So how would we do that, Brian, until we had this tool?
You wouldn't. I mean, I don't know.
So the tool now gives us the insight to do just that. Take a look at that Pareto chart, Allison, quickly, and click on that. So this gives you a brief snapshot. In this particular patient population, there are 16 patients that make up 10% of the spend. Click over to the next box. 58 patients make up 20% of the spend in this population. And the insurers in the audience are nodding their heads because they've known this for a long period of time. We as providers, or as now this evolving delivery system that we talk about, we've never had the insight into this. And Allison, is it legal to click on that and get a list of patients?
Yeah, so what we'll do is we've identified patients with triggers. So those are the patients that are going to be those high risk or have potentially had a recent event that will trigger them into a high risk. So we've hidden all the PHI in here. And so this does give us a list of kind of the patients in here, and then which of the multiple triggers they might have fired up on there. So it's highlighted in blue when a patient's hit one or more of the triggers. And so this now gives the care management team an active list of patients that they can start to work with.
Allison, I'd like to take a quick snap back to the utilization
Before you
page.
do, one sec, Jeff.
Sure.
So one thing I want to point out is that
There's good stuff in here.
we masked all the patient information. But if you notice, the physicians' names are there. And I'm pretty sure Dr. Stubbs didn't get the $124,000 out of that. You know, that wasn't all going to her. But the point is that as physicians, I think it's very tough to see your name up on a board. And we know Dr. Stubbs to be a very good doctor. We're not trying to say anything that way. But what I'm saying is, when you see your name up on the board in front of this audience or any other audience, it's a little bit rough, I think. I mean, how many physicians feel really excited about the data being real transparent like that? It takes a lot. You're excited about that, Brown? Okay, we'll get Brown's up there. But anyway, oh, he's retired. I wonder. But anyway, but the point is that takes a huge cultural shift, and it takes a sort of sense of, I'm willing to be accountable and I'm willing to be transparent with the data. And until I get to that point, we really can't get to this level and we can't start to understand. Because quite honestly, I think Dr. Stubbs is going to be one of the people that knows best how to best manage that patient because she has the relationship with the patient. And if we look at that mechanical model of a top-down thing, the top-down people, well, if they could do it, right, the insurers, your benefit design and your case management would have worked already, we wouldn't be here, right? So we need something different than the system that's been happening before. And I believe that this kind of information allows us to take action in a way that's different and actually execute on all this stuff we've been talking about, how to do population management. Jeff?
So this, once again, gives us the ability to apply differential intensity of resource where it's most needed. From a system perspective, this is a very powerful piece of information in the utilization. And this is complex to start to look at. But if you look at some of these line items, if you look at the medical spend at the very top of your screen, and you scroll across the top of this, the first chunk of this, that 840, is the days per 1,000 member months that are expended in medical admissions. What you see next is this target of 600. That is the Milliman, and Milliman is a company of actuaries that collects a bunch of data. It is the Milliman well-managed benchmark. And that comes back to this idea that I brought up at the very beginning of this, is who needs more information to do a good job? We all want to do best practices. Well, we as a system should do best practices. And so our standard, our benchmark as a system, is that we, I believe, should perform as a national leader at the Milliman best practices benchmark, the well-managed benchmark. White Cloud has also taken this and extended this to a line item that says, in this particular population, what's the financial opportunity for us as a system if we were to manage to best practices? So in that particular metric, there's almost $2 million on the table if we were to manage and put structure in place so that we would manage to best practices. this is replicable on a lot of different layers, as you see here. So the drill down from a system or a population management perspective is incredibly powerful for us as a system now to say, well, whose job is it to manage the pharmacy PMPM? And it's what our payer partners have struggled doing in their own silo, in their own isolation. We now have the ability to bring our engagement, our structure, our pieces together in order to align our business model and now align our clinical model to drive to say, well, shouldn't we be managing to best practices? Shouldn't we? I mean, does anybody argue with that? I would like to be a best practice national leader health delivery system. And this allows us now to parse ourselves down to that, give ourselves targets, and ask the question, where do we have irrational variance? Where do we have rational variance? Because to this point, there will be patients who are sicker and who need to spend money or who have something happen to them, and that's okay. What we should do is understand through things like this, where are our targets of opportunity and how do we manage best to that? Allison, do you have anything else that you want to go over on this?
Let's briefly hit on this one. I think you like to show this one too, the prescription page.
So this gives us a look just briefly about other targets of opportunity as we think about low-hanging fruit. And this allows us to look at where is the pharmacy spend in a way that we've never had the ability to aggregate as a system. And my personal favorite, and I always get chewed up about this, Nexium is a drug that has really no pharmacologic advantage over generic Prilosec. It's an acid blocker type medication. And so when you look at that, we've prescribed $109,000 of medication that probably doesn't confer any outcome benefit on our population. That's when we talk about waste. That is a discrete example in this population of definitive waste that does not confer an outcome benefit on our patients.
Another patient, I had a good example. He was a diabetic and he was over 9. And in the visit, I called up the scorecard. I turned the screen towards him. I said, Jimmy, look, your A1C is higher, and you're one of these 23 people that are giving me a demerit here. Is there anything I can do to get you? And I swear, by God as my witness, his A1C is now down below 8. And that's what it took to activate him. And you're exactly right. The other option is to say, listen, pal, you know, you're out. I'm not going to see you anymore. And I think if that's the kind of doctor we're working with, that's, I think Dr. Coleman brought it up at a meeting recently, ready to go. But, you know, if you're on my team and that's the way you're going to behave, I don't want you on my team. If that's the kind of person you are, and there's a lot of gray zone in there. I get that. Without being unethical, you can still kind of dissuade people from coming back. But at the end of the day, if you think about it, we're all on the same team. You and I are on the same team. We're all working towards the same goal. If we break down the silos and all of that, then we're working together. And if I kick the patient out and he goes to see you, well, then we're still stuck with that guy not doing well. How do we solve that patient's problem? Or, you know, the list is long on surgeries or not surgeries, or screening or not screening, or all of those.
I'm not worried about you or this system, but in bigger cities, there are a lot of shifts of high acuity between practices, from private hospitals to public county hospitals, et cetera. I mean, it has happened in the past. So I was asking a theoretical question. I mean, this data could be used to get rid of patients that are high utilizers.
Could I jump in for a second here? Because I can actually give you an example. I'm Henry Thompson, Pete's GI. I actually run the CF Center for Idaho as well. Cystic fibrosis did all this years ago, and everybody was worried about exactly what you said, and it didn't happen. And the reason it doesn't happen is we provide care in teams. So you right now can pull up my data on how I care for people with cystic fibrosis and compare it to any center in the country. Just go online, Google it, away you go. And so the key is teamwork, and we got to move together. And the better you have the data and not make it punitive, exactly like they're talking about, away we go. The issue that we're faced with here right now in the St. Luke's data that's available is most of it's not applicable to somebody like me in pediatrics. It's adult stuff, and that's because that's what our payers are driving right now. And so our job as docs is to decide, what do we really want to measure, what really matters, and start getting that on there so we can change it.
Thank you very much, Henry. And you know, you teed up Steve Coates, because Steve's going to come talk to us a little bit about how we get new metrics in here that are impactful. So thanks very much.
So we've probably got 500 doctors that are more closely aligned with us in some way in the St. Luke's health system, and another 1,000 we're trying to work with. But of the 500, What kind of adoption do you think we have in terms of utilizing the tools that we're talking about here? What kind of utilization are we seeing, and how do we think that we're going to cascade further the utilization throughout our system?
I think there's a number of layers of answer there. I think number one, if you look at the power of pole slide, that slope of that curve continues to expand. Number two, if you look at the performance, and Allison has this information, if you look at the performance on these metrics, and you can always argue about the impactfulness and the rightness of the metric, but if you look at the performance on this metric and you correlate that to who uses the tool, people who are using the tool are performing. So the tool has validity, and it is powerful for those people who use it. And the third part of your question, Gary, is, how do we get to this point of where we make this tool relevant and meaningful, and we get people using it? That is a journey that we're on. I think what Kurt's doing in the CLC, the Division Medical Director process, the site medical managers, we're pushing this process out more and more and more. And if you look at the example of Magic Valley versus Treasure Valley, Magic Valley is more mature in its organizational structure than Treasure Valley is. And these guys, through the leadership of Brian, Steve Coates, Dan Brown, a bunch of guys in Twin Falls, they've embraced this process. They're a little bit more organized, and they've built it into some of their culture. That's why that trend line for Magic Valley has moved dramatically. It's this idea of physician leadership, it's physician engagement, it's making it fun as well. These guys have made it sort of competitive, so that this is not punitive at all. This is, to Brian's point earlier, this is about doing the right thing, and it's about using a tool that helps float everybody's boat a little higher. Brian, you got any comments on that?
No, I think that my numbers were kind of at the top of the thing for a while, and I felt good about that because I changed my practice to improve the things I was doing poorly. And I felt good about that. But I feel far better about the fact that the internists in Twin Falls and through Steve's leadership, the family docs in Twin Falls have moved the needle. They've changed, they've cleaned up the data, first of all, and made the data more accurate because of the way they run their practice, and they've taken ownership of it. But they've also changed some of their culture. And the problems, like Dr. Simonton brought up, are all over the place. Like if a patient is seen in quick care, they get attributed to whoever that doctor is that's working the quick care. So that has fostered this team approach. Or our gastroenterologists, when they see a high A1C, they send them back to me and say, hey, their diabetes is out of control. So making the data relevant, as Geoff said, and also making sure that it's received in the right context. Because if it's seen as work, and it's seen as this is how you're going to get paid, and this is how you're going to get promoted or demoted or what have you, I think most people are not too eager to sign up for that. That really sounds intrusive, and I personally wouldn't want to work there. But on the other hand, if this is a tool that I can use, that's a positive thing that actually makes the practice of medicine more dynamic in a different way, and those patients that for years have come in with the high A1C or the high blood pressure, it now gives me insight into how can I try to activate them, and at the same time, recognizing that the system is bringing in support for other things, the health coaches, the wellness initiatives, the diabetic educators, and all of that. So to me, it's making it fun and making it relevant is what I think brought it out into the rest of Magic Valley.
Field a couple other questions.
So my name's Tom Fazewski, and I'm day 6 on the job, and really happy to be here as the VP of Supply Chain. And I came from the Marshfield Clinic, which is over 90 years old, and it has 750 physicians. And I just want to congratulate you on the work that you've done here. We aren't doing that at Marshfield Clinic.
Thanks, Tom.
And it's a national renowned organization. So kudos to you and White Cloud and St. Luke's. And I'm terribly excited about this because this is a window potentially into the surgeons and physicians' offices so that supply chain can help all of you, who can then help all of us, right? So my question is, if you take a thin slice through the organization, where the big spends are in the operating room and cath labs and these sorts of things. Have you rolled that into those areas yet for those proceduralists, and what has been their feedback? That's number one. Number two is, I'd commented, but I'd like a response on this issue. I thought that the both of you were a little surprised that some of the physicians in the audience would actually want to see their aggregate data compared to other people. I think there were a bunch of hands that went up. Am I correct?
Only 2, right? Only 2? Which,
Yeah.
oh, 3, okay. Do we have 4?
Yeah, exactly. But I guess, and so the second part of that is, and I think you nailed it, is we need to create a culture where everyone wants to look at everyone else's data, because that's how we all get better. If I have someone looking over my shoulder helping me get better, I'm a better practitioner, and I'm going to do a better job. So just to comment about, so number one, what are you doing in those high procedure, high cost areas? And what, or if you're not, what do you see that looking like in the future? And then secondly, what are your thoughts about moving the entire behavior of the organization to one of not, geez, I'm not afraid to be compared to anyone else, but I want someone else to help me get better. And I know that everyone in this organization has my back to help me get better.
So I don't mind fielding a couple of those. What you didn't see on the other part of the provider here is something called the Acute Foundations tool that does just that. And what we're trying to do is focus our providers into one tool. So the CI scorecard, the first tool that you saw, is very amenable to importing metrics like surgery start times, average supply cost, whatever the case may be. So the tool is built and it's baked to start to put those metrics in it. But it's a process of evolution so that we clean the data up, we have the discussion with our surgeons, we do just exactly what you said in your second comment, which is to create the culture of process improvement rather than the culture of negativity and punishment. And that's a process, right? We have to mature our way through it because it truly is a lot of change management so that people aren't afraid of the data, that we create this culture of interdependency. And Kurt, I think you brought this up, in a couple of things that you talked about earlier. This culture of interdependency is absolutely critical for us if we're going to be successful. I don't know if you got any comments, Brian?
There was a doctor who went to a group of doctors in the system and showed them their diabetes data, and he said, your diabetic care sucks. The conversation ended. The doctors never looked at it again, because why would you? If somebody came and said you're bad at something. If, on the other hand, we change our concept, and this was probably, I went to ATP down in Salt Lake, and Brent James, we talked about how 100,000 lives and all those things. I think we have really good doctors, really good nurses, really good people working really well and doing well. But our system is broken, and the system is the problem. So if instead of saying your treatment for diabetics suck, say the system that we're using for diabetes isn't working whatever percent of the time. I think it's 67% of the time for me. Whatever I'm doing isn't working right. So if we can talk about how we change the system and the process, I think that allows us to start looking over each other's shoulders, because if my partner Daryl's using a different system or a different process for whatever it happens to be, I can learn from that, implement that system in my practice, and the world's a better place. If I just say, well, Daryl's a better doctor, or I'm a better doctor than you and you're no good, then that collegiality goes out the window. And yeah, I don't want somebody just criticizing me as a physician. I mean, you all kind of do anyway, but I don't really want that. So.
Mike.
Mike Adcox, I'm a nephrologist, and I would applaud the work that's been done with White Cloud, but I do have a few comments on the difficulty of shifting the physician culture. And I've been fortunate to work in dialysis units in which we have a very defined population. They have end-stage renal disease. They do not have their own kidney function. And the dialysis chains have been very aggressive in population management, and I can now look at all of my patients. I can tell all the patients that fall out in this particular parameter. The unit is given a particular score, and the arbiters of that score are drilled down to individual patients. And we can now look at that list of 12 or 13 people. And there's some people you just can't change. But what it gives us is the opportunity to recognize the 6 or 7 that you can, and then put somebody else on it, because I'm not going to do that work probably.
Absolutely.
And I come back next month and expect it to have changed. So there's a great example. And with White Cloud, the cultural shift that we're going to have to undergo is twofold. And the first one, when it was rolled out, it was problematic because I get an email every month that says my score is available, but it didn't apply to me. It gives me a 36% ranking. It doesn't do the things I do. And so these generic markers for my body of work are alienated to physicians. Now, I understand the project. I understand why those things were chosen, but we have to be very careful and go back to each clinic now and get it applicable to the obesity docs, get it applicable to the nephrologists. And clinic by clinic, that's hard work. Yep. It's going to take physician leadership and involvement. But once we do that, okay, it can't be treated anecdotally and whimsically. This is what I'm fearful about. So when I get my score, I look at it. Brian, you've taken a few things in your clinic. The next guy may do other things. How do we get the physicians to look at it with rigor and discipline on a routine, periodic basis and change this population?
That is the challenge of change management is to do just what you said, to make it relevant and to make it contextual. I think as we start to move this process, the example you gave in the 6 or 7 patients that you can change, will get the herd moving. We'll start with those champions, those people who have embraced the process and who are putting metrics in there that are impactful to them. And I think the herd starts to move along that process. We shouldn't let perfection, and I think we're guilty of this as docs a lot. We want something fully baked before we start moving. We shouldn't let perfection get in the way of good. And I think we have a good tool and no pressure on you, Coates, but over this next year, as we start to get more metrics in here to come up with measures that are impactful to you, Bob, and you, Mike, as we start to get the herd moving, we'll start to import metrics that have relevance and that we start to move the culture along that journey.
I think there's a comment that people will make, and I'm sort of on a soapbox about this. So one answer would be, potentially, well, you just link it to pay. Personally, I'm opposed to that because then it no longer is any fun. I'm okay with linking pay to algorithmic tasks like chart completion or the number of times you log in or what have you. Or if in aggregate pay is linked in some way to performance, because really when you think about it, there's a lot of money on the table. If I improve my HCC scores, somebody is going to get more money from Medicare. Not me, but somebody. So if there's value provided, how does that happen in a way that incentivizes the right behavior? I personally believe that heuristic tasks like improving diabetic care, improving the overall care of a nephrology patient, if you link pay to that, you'll get what you don't want. You'll get bad outcomes. You'll get people getting rid of patients or worse. So I think I'm sort of, I guess, drawing a conclusion from your question. I think there's going to be a financial impact to all of us in some way, and we have to be very thoughtful about how we do that so that this is incentivized. And the other thing that physicians often say is, hey, I'm on an RVU basis. If I do this stuff, the time I take to call that guy, that's pro bono, right? I'm losing money because I'm not churning the RVUs, if you want to look at it that way, back to the ethical provider, Manu. But the point is, there is a business case to be made for how do we make this relevant clinically, how do we change the culture, and then for the outliers who choose not to, how do we encourage them to join the fold? And it's very difficult.
So I hear bladders are screaming, so maybe one more question here.
Is this on? To Mike's question, I think it's a key question, and if you look at the structure we put in place, if you look at the number of leaders we have, this is a matter of organizational change. We've got all the pieces, we've got the tools. It's a matter of coming together now and seeing how we drive this down in the organization to the extent that we get the highest % of adoption that we possibly can with all these wonderful tools that we've put together. And I think it's a matter of getting the right people together, talking about it, and then deciding how we're going to do it, and if we need to go back to the clinics. But we've got an incredible opportunity here. I mean, this probably is as important as anything we're doing in terms of developing a culture of improving how we do things. And we've got the tools, we've got the people, we've just got to bring it together and get it done.
So I think with that, we'll close with the break.